Good morning, good afternoon, good evening, everyone, and thank you for being here today. For those who doesn't know me, my name is Nasser Al Asmar Piñar, and I'm Genomics Academy Scientific Director here at Genomics Headquarters, part of VitalLife Group in Valencia, Spain. Welcome again to an Genomics webinar. It is true that we are all sick of webinars, and therefore we are only performing now the ones that most of you are requesting. So having a huge menu of webinars almost every day, it is my pleasure to tell you that, as well as on the previous occasions, we have received many registration, actually more than 800. And I find it impressive, not only the number of people registered, but also from how many different countries. In today's webinar, Optimal Implantation Solutions, Preparing a Healthy and Receptive Endometrium, it is a pleasure for me to introduce you our speakers. Dr. Aimee is a fertility specialist residing in San Francisco Bay Area. Practicing for over 15 years, she has a specialization in IVF and has vast experience in helping women over 35 realize their dreams of becoming a mother. Dr. Aimee graduated from UCLA School of Medicine and completed her residence in obstetrics and gynecology at Harvard Medical School. She also completed a fellowship in reproductive endocrinology and infertility and holds a master's in public health management and policy from the University of Michigan. Dr. Aimee is a full-time practicing fertility doctor and is beloved by patients and the media alike. Her focus is on finding the sweet spot of where science and patient care meet and empowering people to better understand their fertility. She launched Egg Freezing Party in 2014 to help educate people about their fertility preservation options. Since then, she's launched the Egg Whisperers Show to further the reach of how she educates people. It's broadcast to YouTube, IGTV, Facebook, Twitter, as a podcast of the same name. It is also my pleasure to introduce you Dr. Allison Rodgers. Dr. Rodgers is board certified in both obstetrics and gynecology and reproductive endocrinology and infertility. Dr. Rodgers' personal experience with both secondary infertility and pregnancy loss have given her a unique insight into reproductive medicine, and she's well known for her compassionate and individualized patient care. Dr. Rodgers is an executive managing partner at Fertility Centers of Illinois and has verified social media accounts with 1.3 million followers, where she focuses on getting accurate medical information out to her followers to empower them to make the best medical decisions for themselves. You can follow Dr. Rodgers on Instagram, Facebook, TikTok, and YouTube. And last but not least, I'd like to introduce my colleague and friend, Dr. Tiffany Stankewicz. Tiffany Stankewicz earned her undergraduate degree in animal bioscience from the Pennsylvania State University and PhD in genetics from University of Kent, where her thesis centered on optimizing IVF outcomes by controlling for both embryonic aneuploidy and endometrial receptivity using genetic testing. Tiffany has over 15 years of clinical laboratory experience as a fully trained embryologist and is certified by the American Board of Bioanalysts, ABB, as a technical supervisor in both embryology and embryology. Tiffany joined Igenomics in 2016 as the PGTA lab manager at the Igenomics New Jersey location. In 2017, her primary focus in the company shifted to endometrial testing when she took on the role of endometrial specialist, concentrating on the ERA ENMA analysis test. And today, she serves as the Global Endometrium Product Director for Igenomics, part of VitalLife Group. But prior to start, let me tell you how it's going to be the next hour or so. First, Tiffany is going to make a brief introduction about endometrial health and how to test it. After that, Tiffany will have an interesting conversation with our two experts regarding different topics related with the endometrium health. And at the end, we will have the Q&A session where you can make your own questions, but please, you don't need to wait until the end. You can start asking questions now if you already have any. Do it during the session or make them at the end of the talk. This is completely at your convenience. And as I always do, we sincerely apologize for the number of questions that I'm likely not be able to ask to our lecturers. We will do our best to try to answer all of them in the next days or weeks. Of course, I also wanted to tell you that, as usual, once today's talk is over, in the next few days, you will receive a certificate of attendance and the link with the recording. And without further delay on my part, Dr. Stankewicz, Tiffany, please, whenever you want, the floor is yours.
Thank you, Nasser, for the introduction. So I appreciate you joining us. I know it's very late in Valencia, so we're really appreciative. So
it's my pleasure to be here today.
Well, thank you. So we'll go ahead and start the presentation. As Nasser indicated, we're going to start with a quick review of our endometrial test. So let's jump into it. So 20% of infertility is caused by endometrial factor. Recent studies led by iGenomics demonstrate that the endometrium is a key factor for reproductive success. Based on our research, iGenomics has pioneered the realm of endometrial testing and IVF, establishing us as the experts in endometrial health. Based on our extensive research, we have not only introduced the original endometrial test with the endometrial receptivity analysis, or ERA, but we have also brought to light the clinical significance of the endometrial microbiome with the introduction of our Aimee and Alice tests. When all three tests are performed together, iGenomics can offer a 360-degree view, ensuring a healthy and receptive endometrium, providing a solution to optimal implantation. We're first going to start exploring with our ERA test. The ERA test was developed and patented by iGenomics in 2009 and is a test designed to evaluate endometrial receptivity. ERA is the original and the first diagnostic test that determines each woman's unique personalized embryo transfer, or PET timing, therefore synchronizing the embryo transfer with individualized window of implantation. Powered by the most scientific background in the market, ERA is supported by 16 external publications and 6 internal publications. Following NGS, a proprietary predictor designed by iGenomics analyzes the transcriptomic data obtained and classifying the endometrium as receptive or non-receptive. With over 240,000 women worldwide having undergone the test, the ERA predictor algorithm learns with artificial intelligence, allowing for continual refinement and learning from those women who've had successful pregnancies following the ERA recommendation. Recurrent implantation failure, or RAF, is the initial indication for ERA. ERA has the highest published clinical rates for patients with RAF compared to any other endometrial receptivity test in the market. Numerous internal and external publications demonstrate the utility of ERA in the RAF population, showing high clinical rates when patients undergo a PET guided by ERA. Looking more closely at some of these publications is a recent publication from just 2022, in which was demonstrated that patients with RAF who underwent a PET guided by ERA had significantly increased clinical outcomes versus those patients who did not undergo a PET guided by ERA, but who instead underwent an FAT at the standard timing of transfer. In a recently published meta-analysis, it was indicated that RAF patients who undergo a PET guided by ERA were found to have similar outcomes to those achieved by good prognosis patients, where in a sense, the ERA has allowed for a normalization of the clinical rates of patients with RAF. Moving along to the microbiome, where we'll discuss Aimee and Alice testing for healthy endometrium. Alice, or analysis of infectious chronic endometritis, detects the bacteria that causes chronic endometritis, a persistent inflammation of the endometrial lining caused mainly by bacterial infection and associated with infertility and obstetric complications. This method is based on DNA extraction, followed by microorganism-specific amplification, that enables the quantification of targeted bacteria present in a sample. ALICE offers advantages over classical techniques such as hysteroscopy and histology with CD138, as it provides objective and specific results, permitting a personalized and targeted approach to antimicrobial treatment versus broad-spectrum antibiotics. ALICE may be beneficial for patients with a history of recurrent pregnancy loss, or RPL, or RAF, as chronic endometritis has been linked to these events with prevalence rates upwards of 60%. This test can also be beneficial for any patient wishing to conceive by assessing the microbiological environment that the embryo will encounter at implantation. EMA, or endometrial microbiome metagenomic analysis, is a test that can determine if the uterine microbial environment is optimal for embryo implantation, providing microbiota information in the endometrial tissue by analyzing 4 lactobacillus species, bacterial pathogens of the reproductive tract, and the bacteria that most commonly cause chronic endometritis. So this includes the ALICE results as well. Again, similar to ALICE, this method is based on DNA extraction, followed by microorganism-specific amplification that enables the quantification of targeted bacteria present in a sample. The impact of the endometrial microbiome in patients with RAF has been demonstrated. However, EMA can be beneficial for any patient wishing to conceive by assessing the microbiological environment that the embryo will encounter at implantation. As far as clinical support for EMA, there are several studies that I'm highlighting here. All are prospective in study design and investigating the microbiome and its effect on clinical outcomes following IVF transfers. In a large international multi-center study by Moreno et al. 2022, they found that the endometrial microbiota composition before embryo transfer is a useful biomarker to predict reproductive outcomes, offering an opportunity to further improve diagnosis and treatment strategies. And in a very nice external study by Dr. Iwami and colleagues of Japan, they demonstrated personalized treatment recommendations based on EMA results can improve IVF outcomes of patients who have been experiencing RAF. Now, I do want to introduce a bit of news. So soon we will be having a new EMA test. So after analyzing more than 70,000 clinical samples and continuously improving for 5 years since we've commercially launched, we're excited to launch the latest version of our EMA test. And thanks to our vast experience, we have further refined the test, leading to a new panel that encompasses the most frequent bacteria detected in the human endometrium, leading to the most precise endometrial microbiome test in the market. So in conclusion, I'd like to introduce the endometrio test. So as you guessed, trio meaning 3. It incorporates all 3 of our endometrial tests, so ERA for endometrial receptivity, EMA, and ALICE for microbiome analysis. So with a single biopsy, we can offer a complete view of endometrial health. So hopefully this quick summary of our test was helpful. But now I want to ask our other 2 speakers, Dr. Aimee and Dr. Rodgers, if they can join us on camera, and we will begin our conversation.
Hi.
Hello. Are we all here?
I'm just messing with you. I'm just messing with you.
Well, thank you again for joining us. So we're very excited about this webinar, and we're very excited to hear from you in your own clinical practice. I guess we'll just jump right into it. And with that said, I know Nasser introduced both of our speakers at the start of this webinar. However, I wanted to give Dr. Aimee and Dr. Rodgers the opportunity to introduce themselves. So let's start with Dr. Aimee. Can you tell us a bit more about yourself?
Absolutely. Hi, everyone. I'm Amy, or Dr. Amy, and I practice in the San Francisco Bay Area. I love helping people become parents, and I'm super passionate about what I do, just like Dr. Rodgers here. I'm just so excited to be hanging out with two amazing, brilliant women who have the same goal, and that is to get people to their pregnancy without extra transfers. So thank you again for inviting me today.
Thank you. And Dr. Rodgers?
Yes, I echo what Dr. Amy said. It's a pleasure to have this evening with both of you ladies. So I'm Dr. Allison Rodgers. I am in the Chicagoland area with Fertility Centers of Illinois, one of the USF practices, and as Nasser so nicely, introduced me. I spend a lot of time along with Dr. Amy doing a lot of patient education on social media.
And I just got your new book. I just got it. And I tonight.
So my book's birthday was yesterday. Oh, look, and I have one right here. Look. So that's so sweet. I'm so glad you got a copy. So yeah, my book got released yesterday. It's a book about puberty and periods. So I don't want to take over the webinar with my book announcement, but I was like, it's been a year and a half in the making, so it's really exciting.
Yeah.
So thank you.
Congratulations. It was perfect timing, so it worked out. But I want to echo what you both said. So I follow both of you on social media, and I think what you offer to patients is amazing, because a lot of times patients rely on Dr. Google, and it's nice to have legitimate advice that you can actually trust. So thank you so much.
And I think there's just a lot of misinformation out there.
That's really true. I completely agree. So it's a great platform to reach patients, and especially educate the new generation of patients, experiencing infertility. So I really admire you both, and thank you again for being here. So let's start. Thank you again for the intros. So beginning our conversation, who are the patients you typically offer endometrial testing to? And for your patients undergoing endometrial testing, do you always offer the endometrial test, or will you sometimes offer only ERA for receptivity, or EMA for microbiome testing? Dr. Rodgers, let's start with you.
Yeah, so I really try to individualize who I offer what test to. And obviously the price point is nice, that if you need, all three tests, that price point is cheaper than ordering them separately. But what I would say is that if we're looking at recurrent implantation failure, where a patient is, you're transferring an embryo, it's not successful. So I will do that typically after 2 untested embryos. I feel like most of our patients are tested these days, but not everyone. 1, if they fail 1 euploid transfer, I will offer it. And then, Dr. Amy and I were talking about this yesterday, is patients who have a very limited number of embryos. And I think that when there's a very limited number of embryos because of a variety of reasons, diminished ovarian reserve, advanced reproductive age, I think that there's a lot of fear about pulling that trigger and putting that embryo in. And I think it gives patients a little bit more reassurance that there's no inflammation, that we're putting it in at the right time. So those are sort of in general who I offer to. In terms of ERA only, I certainly don't offer that as much anymore, but I think if you had a recent hysteroscopy and there was I try to do CD138 on all biopsies that I do, and it was totally normal, and you're really not worried about it, then certainly that could save them a few dollars. And then I actually do quite a bit of Alice alone, or Alice/EMA testing. And I often will do that for patients who are, we're worried about endometritis, and we want to really get that treatment done and figure out what bacteria it is, and or patients who've had, recurrent loss. We're trying to figure out, is there a bacterial cause, but they're having implantation, right? So those kind of things. So those are some of the patients that I usually offer to, but I'm excited to hear what Dr. Aimee has to say about that.
Well, it's basically exactly what you said. So especially for patients with recurrent pregnancy loss, we know endometritis can be a cause, and the EMA and Alice, I think, is one of the best tests that you can do out there, because then you can individualize the therapy for what the bacteria is and make sure it's treated before you try and get pregnant again. So I have lots of funny, they're not funny, there's nothing funny about going through this, but they're fun websites. Well, not even fun, but one of them is Egg Whisperer Diet. So it's diagnosis, IVF, and then endometrial receptivity or embryo transfer preparation, however you want to think about it, then transfer. So I offer these tests to all my patients, and then we talk about whether it makes sense for them to do it or not. And I take the number of kids that they want and how many embryos they have, the implantation rate, and then we decide together, can we afford to go through a couple transfers and have it not work without these extra tests? If maybe there's a 1 out of 10 chance that things might change with the results, and some people might say it makes sense for me to do these tests if I only have 2 or 3 embryos for my family size of 2. For patients who have 8 or 9 embryos, and I know there are people out there that have that, most of them will not, but I've still been surprised where some patients just say, you know what, I still want to feel better and I just want to do it all. And then my angel method is for patients who've gone through miscarriages, is checking that as well. I also think we're living in a time where people are just stressed out, like they sometimes forget their medications, they get reactions to medications as well, and sometimes just running people through a cycle just to see how you respond. Checking your hormone levels before, checking your hormone levels on the day of your biopsy can sometimes just be reassuring and helpful. It's just like a practice run, and then you just don't do a transfer. You feel really good, you feel really ready, and then you say, okay, now I've done all the things that are in my control to prepare for a transfer. I also talk to surrogates or intended parents about maybe doing some of these tests on their surrogates. So in general, I talk to everyone about the test, and then we decide, just like Dr. Rodgers says, who wants to do it and who doesn't. Because I feel like as a patient, if it were me, I would want to know what the menu is that's in front of me, and then I will have a shared decision with my doctor about what is right for me based on all the information. I don't want things to be limited, and then I find out later I could have done these tests, because that would be pretty annoying if it were me.
That's a really good point. I mean, I think it's all about personalization on many different levels. Like you said, finances need to go into consideration. How many embryos? What is their, ideal family size? If we only have 3 embryos and they want 3 kids, we have to try to ensure that those 3 embryos are going to get them there. So I think that's really interesting, especially too what you said, kind of like doing a practice run. I think sometimes when we work in infertility, it becomes so second nature to us that for patients who don't have any experience, it can be very overwhelming. So maybe this helps, build some confidence before going into the real thing. So that's really interesting.
And I think it's all like you have to weigh against time, because it can take some time to do the test to get the results back. And I think that it's really a very personalized decision. And it really has to be a conversation between the doctor and the patient about exactly what Dr. Aimee said. How many embryos, how many kids you want. And I think that that's where it needs to be very individualized case by case.
Yeah, it's certainly, I think IVF we're certainly, it's not black and white anymore. There's whole different dimensions that we need to consider and that patients need to consider. And it's nice having, kind of like the guide, like Dr. Aimee said, like, here's the menu, here's your options. Most likely you're not going to order everything on the menu, but you want to know what there is. So what's going to get you to your endpoint and reach your goals. So it's interesting you said that with like patient perspective, because that's the next topic I want to bring up. Can you share with us the patient perspective when it comes to undergoing endometrial assessments, such as the endometrial trio test? For instance, do patients feel reassured when doing the test, even if the outcome is receptive for ERA and there's no pathogens detected with EMA and lactobacillus levels are normal? So basically saying, yeah, you were fine to begin with, but at least we know that. Dr. Aimee, if you want to start with this one.
Yeah, I mean, I feel like patients feel a sense of relief, and it's satisfying to know that they've done the test, that the results came back receptive, and that there's nothing else that they need to do before their transfer to make it as successful as possible. So I find that most patients, if not all, no one has said to me, I wish I didn't do it. It came back normal. No one has said that to me.
I don't find that many normals. I mean, maybe I'm just selecting the right patients. Every once in a while, I find somebody completely normal. But typically there's something we find. And how clinically significant is it? I think that's, certainly a conversation, and, Tiffany, you can answer some of that, but I think that I almost, and in selected patients, certainly we're not necessarily doing this on every single patient walking in the door, but I find it's like very few people are receptive. I mean, there are some, of course, but I think that a lot of people need extra progesterone. A lot of people have, and I'm so, I was gonna say anal, but I'm gonna say thorough. I'm very, very detailed about how I take
your
the
next book has
biopsy.
to be about the anus next.
Well, if I have to find a gastroenterologist to help us. So, but I'm really like very specific. I'm like not touching the sidewalls of the vagina with the biopsy pipella. I'm like literally going right into the os, not touching anything else. Like I don't want any bacteria from the vagina getting into the sample. Like I'm very, very specific about how I take this test or I pull the test, in terms of the sample procedure itself, as I'm sure the providers who are listening are. But I think that it either way, whether if we find something, I think patients are like, great, let's fix it. And if we don't find something, I think they're like, great, let's get pregnant. I do think there's a small subset of patients who, have had recurrent implantation failure or recurrent pregnancy loss, and we do this test and it's totally normal, more for maybe recurrent implantation failure, and we're kind of not hoping it's abnormal, but like it would give us an explanation of something that's very, very fixable, that we can just add some extra progesterone, and if it comes back totally normal, I think that can be hard for some patients. So I think that's important to sort of realize. But I think the bottom line to patients is that if it's normal, that's a great sign.
Yeah, exactly. And I think it kind of omits that future, like, what if? So if they don't have a successful pregnancy with the next transfer, they're not thinking, did I do everything I possibly could? They feel more confident in moving forward. So I think that's, what we usually hear from patients. So in the case of Emma, the indicated population can be expanded beyond RAF. So Dr. Aimee, you were saying this is something that you offer your intended parents for their gestational carriers, as none of us are immune to dysbiotic microbiomes from time to time. Speaking of the microbiome, the advantage of the molecular testing platforms such as Emma is that we can actually identify the bacteria that is present in each patient's endometrium, allowing for personalized care with targeted antimicrobial therapy versus the use of broad-spectrum antibiotics. Can you tell me about your experience with Emma versus other methods for chronic endometritis detection, such as histology or hysteroscopy? Have you seen improvement in actually curing chronic endometritis cases when applying a more targeted approach, guided by the Emma results, versus a more, say, blinded approach with the broad spectrum antibiotics? Dr. Aimee,
I mean, what I would say, it's a lot more satisfying to know what you're treating. And then that it's not just doxycycline for 2 weeks. It might need to be something else like Cipro or Flagyl. So I feel like not going in blind and then repeating the biopsy and making sure it's gone is also very satisfying to know that it is now gone. I know not everyone does that, but I know a lot of physicians do that. So I would say that that's why I like the test, because I know what I'm treating and I know what antibiotic to use, and then I can repeat the test and make sure it's gone, rather than, if plasma cells are still there, you're like, what do I do? Another 2 weeks of doxycycline? Like, where do I go from here? How do I know what to use? And you just guess about something else. So I feel like this is, basically has taken the blindfold off and has made it very clear and easy for doctors to treat this.
I will say that before this test was available, and I'm sure, Dr. Aimee, you had a similar approach where like you would do a biopsy, you would see a positive CD138. I actually would, my usual first line, if we're not doing any Alice Emma testing, would be to usually I'll give Doxy plus Z-Pak, and then rebiopsy. Like let them have a period, get that lining out, rebiopsy. Then if it's still positive, right? And think about it, then the patient's having to go through a second biopsy, which is like not fun, right? It doesn't require anesthesia, but it's also like real not fun. It takes a week or two to get those results back. They're paying for path a second time. Like it's just a lot, and the patient, and they're delaying care even more. Then my second round was ciproflagyl. And then I would let them bleed, rebiopsy, and then if they needed something else, I would use like a strong like moxifloxacin or something like that. And that would take months, absolutely months, to try to figure out what, you know, what bacteria, what antibiotic. And you know what I was most surprised when I started using this test, and it's been a few years now. When did it get released, Tiffany? 2021?
We just celebrated, yep, we just celebrated 2 years in February. So
right. So, you know, when I started using this test, and I would find things like E. coli, like some of these bacteria that I wasn't giving any antibiotics that would have treated it. I'm like, oh, I should be using Bactrim. Oh, I should be using whatever other, you know, and the nice, you know, that's like, I was like, oh, I wonder how many other patients I should have been using this bacteria or this antibiotic for this particular bacteria. But like, we had no idea. We're just using sort of what is usually in the pathogens in the vagina and the uterus and what we think. It's just sort of, it's really taking from like, let me just throw something at you and see if it works, to it's this causing a problem. This is what you need to treat it.
No, and I agree. You know, we're targeting the bacteria in the endometrium while at the same time not overloading our patients with unnecessary antibiotics that are affecting their microbiome elsewhere in their body. So I think the microbiome is becoming, you know, more and more central to focusing on our overall health. So it's important, you know, again, not to override our patients with antibiotics unnecessarily. So I think this helps avoid that. But it's interesting you mentioned the test of cure. So on that same topic, do you both routinely perform a test of cure following antimicrobial treatment? So just to give you an update, recently we have updated our recommendation on our Emma and Alice reports in the US, indicating a test of cure biopsy following antimicrobial treatment, because we want to ensure that, yes, the treatment was successful. Sometimes with complex profiles or maybe more complicated bacteria like Gardnerella, the patient may need more than one round of antibiotics. So this can help decipher, okay, should we proceed with transfer, or do we still have some pathogenic bacteria that we need to rid? So Dr. Rodgers, I don't know if you want to start with this.
So yeah, obviously those are newer recommendations. And I think that in general, when I'm just sort of throwing antibiotics at someone who didn't do maybe Alice Emma, I would absolutely do a test of cure. I think when we know the pathogen, we know the bacteria, obviously there can be resistance, but I'm not routinely doing that. But my practice with this new recommendation may change now that that's on the report, I think. And I also think that's maybe an individualized decision, right? I think that if you're talking with a patient and they're like, okay, we found this bacteria, we treated it, and they have several embryos, way more than they want children, like maybe that we just try it, and then if that's not successful, then rebiopsy them, because as you know, biopsying takes some time, and I think time is the one thing that patients don't want to waste or spend time, right, when they could be moving forward. And I think that, you know, in general, it's certainly going to be a individualized decision. So I have a question for you, Tiffany. So if you are doing, for example, let's just say, for example, just Alice testing, and then it needs to be repeated, or Alice Emma testing and it needs to be repeated. So if you have to repeat the ERA, there's a cost break if you had to redo it for patients. Is there also a cost break if you have to redo it?
For the microbiome. Yeah.
Oh,
for the repeat biopsy.
That?
Yeah.
Are you able to say? It's different. Okay, we don't have to talk.
No, it's fine. I stay out of pricing, so I'm not sure. But there is.
I just said so there is a reduced price if you needed to repeat it, because I think that is nice for patients like who are doing the ERA, or you know, if you had to repeat the ERA at some point, it's a lot more. You know, it's reasonably priced.
Yeah. And we're conscious of that. So we want to give that price break for the repeats, especially for the test of cure, to make sure we're good to go with a healthy endometrium. Sorry, Dr. Aimee, I think I interrupted you.
Oh, I was going to say, I'm also curious about whether Dr. Rodgers, you not test. I don't think we can test a guy's vagina, but in a in a heterosexual relationship, do you treat
I
prescribe?
don't. Maybe I should. I don't routinely, because I feel like what's in the vagina isn't necessarily what's in the uterus,
Right.
because it's, but I don't know.
I've just been personally debating that myself. I was just curious what you do. Yeah.
Tiffany, I have a question for you. So let's just say someone turned positive for a certain bacteria. You treat them with a 7 to 10 day course or whatever, 1 to 2 week course of antibiotics. I know that my nurses are always really good. Some of them may be listening, but always saying, genomics doesn't like it if you're giving them antibiotics too close to their biopsy, right? Because then dead bacteria are going to show up, on the biopsy, right? So is there a certain amount of time you have to wait from the time you do you give the antibiotics, and then when can you do the test to cure?
So we usually recommend, because we want, ideally, you want to take the test of cure, or you want to transfer in the cycle following the biopsy cycle, because we know that the microbiome can shift over time due to factors like antibiotic use, obviously, sexual intercourse, hygiene, etc. So if you are treating the patient and you're planning on a test of cure, you can start treating them as soon as they get the results back. So treatment, when we have a pathogenic bacteria, looks like antibiotics first, and then followed by vaginal probiotics to replenish the lactobacillus population in the endometrium. So if you're just repeating, say, the EMA, you don't have to replicate the endometrial cycle with the ERA. So you can give just during a natural cycle or birth control. It's a really, that's a really common one in the US. So the patient doesn't have to undergo, estrogen and progesterone, HRT. So our recommendation is to take that test of cure biopsy in the following cycle, or if say the microbiome is normal or just dysbiotic with abnormal lactobacillus and you're just giving probiotics, you can transfer in that next cycle. Because again, we want to test the microbiome, soon after treatment, or transfer soon after getting, good results.
Makes sense.
Yeah. So, all right. Okay. So speaking of efficient workflow, this is all flowing very nicely. Although a test of cure biopsy adds another month onto the overall treatment for a patient, I do think it's beneficial to ensure an optimal endometrium. As I said before, especially in the case when we might have complex bacterial profiles where several pathogens have been detected, or in the case with those more complicated bacteria like Gardnerella, where they can sometimes be tricky to treat. With that said, of course, we know patients wanted to be pregnant yesterday, not have to wait another month. Do you have any tips yourself on having an efficient workflow to get patients to transfer sooner than later when they're undergoing endometrial testing?
Yeah, I mean, for me, it's as soon as the results come in, we communicate with the patient that day. And the way the results come in, typically their period's starting at the same time as the results are coming in. So it actually works very nicely. So if there is a positive finding, excuse me, I put them on birth control pills, treat them, and then do the test of cure at the end, potentially. So I feel like it doesn't really take that much time out of my transfer planning if they get a positive test, because of the length of time it takes to get results back. I mean, I imagine some clinics, potentially the results come in and it might take time for someone to communicate with the patient and follow up with them. So then it could take an extra month or so because of that. But I find that the results come back to me in a time efficient way so that I could move forward right away.
What would you call, how long does it take you to get results back in average, Aimee?
I mean, it feels like less than 2 weeks.
Tiffany, do you have so I think in our clinic it's closer to 3 weeks. And so I don't know if sometimes it depends on the time of year or probably but I think it's about 3 weeks in general. Is that what you would say, Tiffany?
So the turnaround time for all the endometrial testing is 15 days. When doing an endometrio, we release the report at different times, because whenever they're ready, we want to get them out. And usually it's Emma and Alice first, because the lab protocol is is shorter than ERA. And it's also helpful because you can initiate treatment ASAP.
Right away.
So I would say in most cases, we're getting Emma and Alice out in probably less than 15 days.
That's great.
You know, it's only those times where it goes over if we're missing, something like patient consent or a signature that's kind of holding up the process. But in the majority of cases, Emma and Alice is released usually well before 15 days. But we give the 15-day turnaround time as the standard.
Yeah, so it depends on what we're planning on doing next. Sometimes sometimes we're doing this as a bridge to an IVF cycle. So like a patient failed a transfer or had a miscarriage and then I'm bridging it. So like I will do a luteal biopsy and then like you do like whatever it is, luteal estrase priming or and then like roll that into an IVF cycle. So I can actually be just giving them their antibiotics and waiting for results while I'm doing an IVF cycle for them. I think that if they're doing a transfer next, it really depends on if they're doing sort of a more modified natural cycle transfer or a hormone replacement. A lot of times, it's easy enough to hold patients. Actually, the day of biopsy, I'll just switch them from, the day of biopsy for an ERA cycle. They're probably on progesterone and oil and some, usually my protocol, I'll have some vaginal progesterone and some patches and some pills and like all the things. I usually just switch them to estrase and agestin. Agestin, I like as a progesterone because it's a nice, strong progesterone that can like hold them from like the dip in progesterone that would cause a bleed. So I put them on 10 milligrams of agestin and 2 milligrams twice a day PO of estrase, and I can literally like just hold them there until those results are back. And then I agree with Dr. Aimee. We can treat them with antibiotics if we need to, and then roll right into their treatment. So I think that it's very helpful from that perspective.
Yeah, and those are great tips because I do get those questions a lot from physicians. How can we not delay any further? So I think how you explained, your different methods to getting patient, like just to keep going right through is super helpful because, like I said, there's sometimes patients will have to wait an extra month between performing the biopsy and actually starting the treatment. So ideally, we want them to start treatment as soon as possible. So those are great tips.
It really does also sort of depend on workflow of the clinic because
Mm-hmm.
I think that, there's a lot of clinics out there that have a hard time sort of managing that workflow for a variety of reasons, lab, scheduling, nursing flow, whatever. So I think Dr. Aimee and I have a very similar kind of style of practice. And we get those results to patients. Maybe we don't have time to do a full consult, but we've already consulted the patient that like, if a bacteria comes back, we'll know which antibiotics. And then it's very easy for the nurses to say, you came back positive for whatever it is, and we need to treat you with this antibiotic. And then by that time, we're able to get them back in for a consult. So I think that it's also sort of about setting up expectations. And when you're consenting the patient for the test, having that conversation that, these are the things we do based on the results.
Yeah.
I think that's a good point, is setting the expectations, because you're right, every IVF center works differently. So I know both of you are very quick to review your results because, if you call me asking for my opinion, the results were just released. So, yeah, I think
we love that about you, Tiffany.
In that sense.
Thank you.
I love that I can just call you and be like, I have a question about this patient. I don't understand.
I'm very happy to help. We've been working together for a long time, so I really appreciate that. So moving forward, as we all know, implantation is the major rate-limiting step for patients to achieve success in the IVF cycle. For so long, we've focused on optimizing the embryo, but now we're giving more attention to the endometrium. I think IVF is evolving to a more personalized approach to treatment, and we're exploring more ways to optimize the process. So we've heard recently about clinics utilizing multiple tools. Obviously, my interest is in optimizing both embryo for aneuploidy or with PGTA and endometrium. But they use tools such as ERA, Emma, embryo glue, PGTA, time lapse, and so on in order to optimize specifically the implantation process. Can you tell us about which tools you commonly use together, where you have experienced improved outcomes for patients. Dr. Aimee, if you want to comment first on this one.
I can, and what I can say is I'm probably most patients won't hear the approach that I'm about to share, and that's okay. I sometimes do things a little bit outside the box, but I do them because they don't cause harm, and I've seen them work time and time again. So I brought uterine PRP into my practice. In April, I bought it for myself, the machine, as a gift for my 46th birthday. So that was, I know you guys are all surprised that I'm 46, I know. But that was last April. And it was because I was sending patients who had implantation failure to Stanford for a study that they were doing, and my patients were getting pregnant. And so I was like, you know what? I don't need them to like go through another process of onboarding with another doctor. I'm going to do it myself here. Got the equipment, learned how to do it, and it's been working really, really well. The other thing that I do sometimes is add HGH to a protocol to improve uterine receptivity. I also add supplements like L-arginine, vitamin E, and a number of other things like maybe steroids, aspirin. Sometimes I have patients talk to a reproductive immunologist. I also use something called red light, low-level light therapy. It's basically a heating pad, and I kind of sound a little woo-woo when I say it might decrease inflammation in the body and increase blood flow to your uterus. Doesn't that sound like weird that a fertility doctor is saying that? But again, I've had patients who've had so many things not work for them, and it's not that I can say one of these things is what worked. I can say it's a combination of all these things, and then they get pregnant. The other thing that I've also utilized, and it's because I'm lucky enough to have a site close to my office to use, is hyperbaric oxygen therapy. So some patients, I have them do sessions at an oxygen they sit in a tank basically about 60 minutes a day for 7 days. And this is more for patients who have a thin lining. And then the other thing, I have a couple other things, but I'll stop here, is the Receptiva DX test. So it's a test for silent endometriosis. I actually do 4 tests with the biopsy. I do Emma, Alice, ERA, and then I put some cells into another tube and send that to Cicero for silent endometriosis testing as well. So that's just a little bit or a lot of all the things that I think about when I treat a patient and we are reviewing what we're going to do for transfer.
So I don't do all of those things. I love learning from Dr. Aimee because she is always really like on the cutting edge trying things, and like she'll tell you like some of the stuff has science behind it, some of it doesn't as much, but it's not going to hurt you, so maybe it'll help. So I am always asking for protocols and fun things from cool things to try for patients that are having a difficult time. But I don't offer typically Receptiva at the same time. I'm pretty select in who I offer the Receptiva test to personally, because if it's positive, then I'm going to recommend 2 to 3 months of medical suppression with Lupron. And if we're not there yet, obviously, and it adds additional cost to the treatment, it's doubles the price or whatever it is. So if we're not quite there yet to the point where I would be offering that to them, I typically will wait a little bit on that one. So I don't often do that all at the same time, but although I did one yesterday and we did all, I sent it for all 3 of those same exact things. So it really, again, is a very case by case basis. Obviously for patients, I think, optimizing tools like we talked about, plus sometimes hysteroscopy. It's straightforward to do office hysteroscopy and take a look. I'm sure Dr. Aimee would agree with me that there are certainly times where like I do a saline, and I know the studies are out there and I've read them that saying that 3-dimensional saline sonogram with a high quality machine should pick up any pathology that is significant enough to cause implantation failure compared to a hysteroscopy. And I know we've all read those studies, and I agree that my super high tech 3D ultrasounds that I do my salines with are phenomenal. That being said, there are 100% times where I do put a scope into a uterus and I find something I wasn't expecting. Maybe it's a little bit of scar tissue. Maybe it's a little bit of like retained tissue that was flat. So maybe it was like flat, so I couldn't see it popping up on the ultrasound image. But I do utilize that as another tool that hasn't been mentioned yet, as sort of to see. And these are really in recurrent implantation failure patients, right? So if you are just sort of, yay, you have male factor or have tubal factor, and we're like, you know, getting you pregnant, you know, and you're, you know, you got embryos and you have a good prognosis, you know, and we're just putting in embryos and you're getting pregnant, great. But if we're putting in embryos and it's not working, and then we're putting in embryos and it's not working, that's when we need to say, what else can it be? And I always break it down to patients when I'm talking about failed implantation, failed transfers, and it, like, into this sort of, just like you said, Tiffany, sort of it takes a healthy embryo and it takes a healthy uterus. And certainly doing PGT testing on embryos is sort of all that 2023 has to offer us right now, in terms of the technology on testing these embryos, right? I know there'll be more amazing things from iGenomics soon, I'm sure, but right now, PGT is all we have, right? And so when we're, you know, if we've done that, great. If we haven't, maybe that's something to do. But then, like, what else can we do to assess the uterus a little bit further?
Yeah, and I agree. I think a lot of your techniques that you just explained, they have to do with uterine health and optimizing the endometrium, which, again, we've kind of, until recently, haven't paid much attention, but I think we're shifting a bit of focus to understanding the importance in implantation. So,
and I'll also add real quick,
oh.
Tiffany, real quick, I'll also add that I have done, because I had the question, if uterine PRP would affect the ERA results, and it does not.
Good to know.
Okay.
So I've had a
Thank
patient ERA, no uterine PRP, then do the ERA with uterine PRP, and because I just needed to know for my own sanity. Same. So I don't feel like, and I've had so many patients who've done the ERA without uterine PRP, and then they've gotten pregnant with the same, you know,
That's
protocol.
good to know.
It felt like I don't have to do the ERA, because the question is, do you do the ERA with the uterine PRP, right?
Oh, right, because PRP is expensive. I mean, not that expensive. I mean, compared to other things we do, maybe not that expensive.
Yeah. I mean, it's like $500 to $700, depending on where you live. So, yeah.
Yeah, no, it's always helpful, because it's impossible for us to study every treatment or every medication on the reproducibility of the ERA results. So our general recommendation is, you know, if you're going to use something, then make sure it's replicated from cycle to cycle. But some of these treatments are more expensive, so that needs to be considered. So you know, thank you for sharing your mini study. So that's exciting. So as we're wrapping up our conversation, really quick, just a couple minutes, if you can share maybe a complicated patient case that when following the endometrial test, the patient was able to achieve success. I know we all have those stories where it's like, wow, this patient's been through absolutely everything. So it's always interesting to hear these positive outcomes. Dr. Rodgers, if you want to start.
There's just, yes, and I will tell you, I've had so many stories like this. I specifically will tell you that I've had a couple patients who have seen me as a second opinion from other providers who have had recurrent implantation failure, and they just feel like they're not being listened to. I think that's always a really hard place for patients to be, or feeling frustrated that treatment isn't successful. And you know, this is somebody who'd had, you know, a couple PGT normal embryos not work, you know, and we did the endometrial test, needed extra progesterone, needed some antibiotics. We treat them, we add the progesterone, and then pregnant. And it's so good. It feels so good, right? So, you know, I think that obviously maybe who knows, maybe this other provider didn't think that this patient needed it, or I can't speak to what their practice is, but, you know, I think that you know, there is absolutely patients who really, really benefit from it. And I think that some of the questions that we'll probably get into when we get into the Q&A a bit is really trying to identify which patients those are.
Dr. Aimee?
Yeah, I mean, I have a couple. I mean, the first patient was the first case I ever did the ERA on, and that was a patient almost 10 years ago where she had 5 transfers, none of them worked. Her doctor said, you need a surrogate, and I found your test, and I've been a believer ever since. Her her timing was shifted by 48 hours, 2 whole days for a blastocyst. And I was like, that's insane. Like, I've never seen anything like this. So I actually put her through a second test and it came back the same. I'm like, this is crazy, but we're going to do it. And we did it and it worked the first time. She had to do a whole nother IVF cycle because she was out of embryos, but that's how it worked. And then another cool story is when the trio first came out, when Emma and Alice was first, I had patients who had done ERA and they didn't have Emma and Alice. And I'm sure, Dr. Rodgers, you remember this. So I had a patient, she did 2 transfers with me. We did ERA after the second one. And then, or after the first one, because everything was like perfect. I'm like, this doesn't make sense. These embryos are gorgeous. Like they have to have, like this had to have worked. And so I said, you know what, let's just do Emma and Alice. And here we are. She's pregnant, had a baby, and there was something that came up positive on her test. I treated it. And the thing is that I give everyone antibiotics. I give everyone doxycycline as part of their transfer, but this required a different antibiotic that I would have never given in the first place. And her next transfer worked. So that's why I feel like these tests can be important for some patients.
Yeah, agreed. Especially when you see those outliers, like you said, with 48 hours, more progesterone exposure needed. Those are always the ones that make you scratch your head and you're like, okay, well, let's try this. Or when they need, 24 to 36 hours less progesterone.
Right?
But
like it seems so
works.
short. It's so funny that you said that, Aimee, because my very first ERA success, which again, you're right, it was like 8 years ago or something. I specifically remember because she'd had biochemicals, ectopics, kept doing cycles, kept not getting pregnant. And like, I was like, I found this test. I was thinking there's gotta be something going on. 12 hours. And I was like, I don't know. That doesn't seem like very much. 12? Now she's got 4 kids.
Wow. Amazing.
Wow.
I love it.
Yeah.
Yeah. It's sometimes those little shifts or, sometimes we're, what we've seen from transcriptomic profiling with ERA is that we have various lengths of the window of implantation. I mean, we've seen one window of implantation less than 12 hours long. So being very precise in that timing is integral for that particular patient. Now, other patients we expect, about, a day or and a half, the window of implantation length, but we know there's those patients out there that exist, but it's very narrow. So being able to have that like transition phase result where we just shift 12 hours earlier in the case of late receptive is can be really important for some patients. So thank you. I always get goosebumps when I hear about these cases because working in clinical IVF before joining iGenomics, you become very dedicated to your patients and you wait for their pregnancy test to come up on the machine and you feel, like you're really part of it. So thank you for sharing that. So I think with that said, we'll invite Nasser back. He's been probably shuffling through questions as they've been coming in. So I'm sure he has some good ones for us.
Yeah, I'm so sorry to interrupt you because it was amazing to hear everything that you were sharing with us. So thank you very much for this nice conversation. And yeah, we have some of questions coming from the audience. I already saw some of the names. There are some colleagues and friends, professionals on the reproductive medicine, but also I guess that we had some patients because we are keeping from the very beginning saying, hey, I'm a huge fan of Dr. Aimee. Hey, I'm a big fan for Dr. Rodgers. So I think that we have a lot of patients as well. And the thing is that I would like to remember that every question that we cannot answer now, we will do it later on because I can see a lot of questions that are specific for patient and asking different questions regarding their tests. So this is something that we will do later on. But just to start, there's a question asking, based on your experience, what would you consider are the most important signals we have to look for to recommend an ERA test? I don't know if signals or could be the indication, probably indication.
So,
go ahead.
Yeah, go ahead. So I would say and this is really going to depend on your, like Dr. Aimee said, the patient's goals of how many children they want and how many embryos they have. And So in a young patient who might be able to be successful in 2 years when they're ready for their next baby, they're still young enough and have a good deal enough ovarian reserve to be able to be successful again. It's maybe less concerning than somebody who might have diminished ovarian reserve, and once they have their baby, we may not have another chance at getting more embryos, and so they might have very limited numbers. I think limited number of embryos and recurrent implantation failure are the two main people that I recommend this test to.
Same, 1 embryo, 6 cycles to get your embryo. I would say do the test. That's my recommendation.
Oh,
yeah.
Perfect, thank you. And there is another recurring question asking about what are you doing in your experience with endometriums that never ever grows?
Hard one.
Yeah, I mean, for me, thin lining, it's the recipe that I reviewed earlier. So uterine PRP, sometimes I can do it up to 3 times, even more sometimes in a cycle, and then trying different transfer protocols. Modified natural cycles are one of my favorite types of protocols to help people get to a thick lining, and that's assuming obviously someone who has eggs that they're ovulating, because some people, you know, you're in a stage in your life where you're not ovulating and you have to rely on high dose estrogen injectables, you know, estrogen patches. But even in those patients, I've been very lucky in being able to get them to a transferable lining with uterine PRP and all the other things that I mentioned. And I've also been using something called TEAS, TEAS, transcutaneous electromagnetic acupuncture stimulation. Doesn't that sound nuts, Allison?
I love your acronyms. You've got acronyms for everything. I don't think this one's yours. But there's acronyms for everything. I was like, what is Tushy? You're like, oh, let me tell you. Tubes, uterus, sperm. I got it.
Yeah, so there's like so many things, and I do it all together. So I put patients on a plan, and that's how I deal with thin linings. I know there are other things that people do like Viagra. I just have not been impressed with Viagra. It sounds very sexy and stimulating and exotic, but no, I have not been impressed with the results. Erotic, not exotic.
Stimulated transfers as well, like you said, maybe not even modified natural, but like stimulated, where you almost do like an IVF cycle without the retrieval part of it. But these are some of the hardest cases, and I will tell you, like, these are some of the cases that I would do an ERA on. So if you have a limited number of embryos, you have a thin lining, and you know we don't want to mess it, we don't want to get it wrong. You know, maybe I have a couple patients who, you know, we all have a couple patients in our practice, the thickest they can get their lining is maybe a 5 or 6, you know, goals usually 8 or higher, right? And sometimes, you know, we want to see that nice trilaminar appearance, but really sometimes these, sometimes patients, that's all they can get. And if they're receptive, it can work. I mean, I will tell you, I have a patient who, you know, unfortunately went through donor eggs because she wasn't getting pregnant, went through donor eggs, kept not getting pregnant, and was in one of these like guarantee programs, and then ended up getting her money back, and then ended up getting a different donor. And this was right when ERA came about, and I was like, let's do an ERA. Of course, it was like 24 hours off, first transfer, she got pregnant, and I was like, you know, this is like a new test at the time, but it's like, I mean, maybe it would have worked with your own eggs 5 years ago, but we didn't have the test available at that point, right? But I think that, but she had a really thin lining. It was only 5 millimeters. But when we did the ERA, it was, you know, it just needed a little bit of adjustment, but it still was receptive. It still held a baby just fine. So I think that, you know, certainly some patients who've had instrumentation of their uterus, you know, DNCs where there's, and you know, I think most fertility doctors are like so delicate and gentle, like they don't want to do anything like, you know, to disrupt the endometrium. But, you know, they're certainly in the best of hands. Even sometimes things can happen in terms of the way people heal after miscarriages or other surgeries or whatever. And a lot of times, you know, even patients who've never had any instrumentation of their uterus sometimes can have really thin linings. And, you know, but even sometimes thin linings do a good job, but I think this is where a good patient for an ERA.
Yeah, thank you very much. And this is something that I think that it's aligned with our data. We observe that patients with an atrophic endometrium has a bigger percentage of non-receptive results than the patients with a normal thickness of the endometrium. But then when you transfer, when they are receptive, it works. So yeah, our results support your ideas. Mm-hmm. So Tiffany, the next one I think is for you. Well, there are some people that looks like that the part of the test of cure was not clear because they keep asking. So I think that they need to wait 1 week after antibiotic completion before the biopsy for the test of cure, right?
Yeah, I mean, they need to complete the antibiotics and then the probiotics. So the probiotics innately in itself, inherently, you know, can range depending upon which probiotic you use. You know, typically it can be anywhere from like 3 days to 10 days, depending upon the actual probiotic. So that's kind of built into the time.
Okay. And another question for you is that you showed some data for papers talking about the ERA and the good results, but how about the latest publications that are telling that ERA apparently is not working?
Yeah, so I am not surprised we received this question. So, you know, we know that ERA does work. So ERA itself is backed by the most scientific publications for any endometrial receptivity test in the market. So as I mentioned, we have 22 publications, both internal and external, supporting the use of the ERA test. So I think that just it inherently comes with the territory. So being the pioneers for endometrial assessment and health, you know, we've been around longer than some of the competitors were the original tests. So just the fact that we've been around for more than 10 years, we're going to have more scientific publications, both positive and some negative. But I think we have to look at the proportion of the positive to the negative. As I said, we have 22 supporting ERA testing and the utility of that, and then just a minimal with the quote unquote negative publications. And I say quote unquote negative publications for two reasons. One, we have to consider what was the study population in those papers. Were they looking at the indicated population for ERA, which would be initially RAS patients, or was this a good prognosis patient study? So even in a recent RCT, they found no benefit in the good prognosis patients. Well, in this sense, it kind of validated our previous RCT where we didn't see a significant improvement in live birth rate with the first personalized embryo transfer, but only after a cumulative embryo transfer. So this was something that was not included in the new RCT. So that would be interesting if there's going to be a follow-up to that. And then the other thing we need to consider is proper protocol compliance. So we know that sometimes the ERA can be tricky, you know, especially with patients, you know, understanding that we have to replicate the cycle exactly. We have to ensure endogenous progesterone levels are properly controlled for. And we know that no one is immune to this kind of patient dropout. So we have to consider, was this properly controlled for? So even in our own experience with our RCT, we had a 50% dropout rate, mostly due to this lack of protocol compliance. So we see that sometimes it's you know, it's not always followed exactly. So how I explain the ERA, it's very similar to a science experiment. The only variable that we're changing here is progesterone exposure time. We don't want to change the cycle type, so we don't want to do the biopsy in a natural cycle and transfer an HRT. And even within the same cycle, like so say we do an HRT for both, we want to keep the progesterone type and dosage the same. The only thing that should change is exposure time. So until we can validate that everything was carried out properly, you know, we have to consider the results with caution. Now, again, as I mentioned, you know, this is kind of, we're bearing this cross in the sense that we're the pioneers when it comes to endometrial testing. So having a large amount of publications, we're going to tend to see the negative, you know, compared to some of our other commercially available receptivity tests out there that may only have 1 or 2 publications. You know, we're bound to have some negatives in there. But I think, you know, when reading these publications, keeping that in mind, what is the study population, and validating was, you know, the protocol properly carried out is really important.
I think that's a really good point. Because I think if the, certainly there are patients listening to this as well as providers. And I think that if you're a provider, like I think probably, Dr. and Aimee, I sort of said, do we need to change who we're offering this test to? And I didn't really necessarily change it a whole lot because I'm already not offering it to every single patient that walks in the door, but just patients who need it or based on their individual situation. And I think so if you're a physician, I think that's the question you need to ask yourself. Are you testing the right patients? Based on this data plus all the other data. And then I also think that if you're a patient listening to this, I think that you need to be asking yourself, should I be getting this test? Do I have a very limited number of embryos that's hard to get more? Do I have recurrent implantation failure? And if it's, I think that you need to ask yourself, do I fit that patient protocol, that patient type? Or like Dr. Aimee said, there's some patients who really don't need it and feel like, they would feel better, feel more confident going into a cycle because there's a lot of emotion involved. And there's no harm to doing it. It just takes time.
Yeah.
So if you're that kind of patient, then, and you feel like you want to do it, it's just important to realize it may not help your chance, but it's not necessarily going to hurt your chance.
And I've seen a lot of people applying the rules inappropriately or incorrectly. I'm sure you've seen it too, where a clinic will do it and then they're not applying the ERA rules to the transfer cycle, or they are doing a controlled cycle and they use the results and apply it to a natural cycle, which doesn't.
Agreed. It's really frustrating.
Yeah.
And it does the patient a disservice.
Yeah. And I think some of these negative publications, I use the air quotes under negative because, we've actually used some of this to actually improve our test. So we can pinpoint maybe those clinics that aren't performing it correctly and try to help them optimize their outcomes by kind of fine tuning their protocol and making sure that there's proper compliance. With having upwards of 15 times more clinical and scientific publications versus, say, our competitors, and ERA being the most widely used test with, I think it was over 240,000 women worldwide, we're able to learn from all this experience, whether it's good or bad, and provide the most precise test for patients out there. So we take it more as a learning experience and how can we improve ourselves and how can we improve the test out in the field. So, a lot of people come up to me and they're like, oh, how are you doing, the negative publications? But, I think there's something we can all learn from that and make it better. So, I'm glad you mentioned that with, the patient perspective and kind of fine tuning, who you're offering it to.
Thank you very much for your answers. The thing that the time it's about to finish. Actually, we already passed the time, but for sure we will answer all the questions. We will send through Dr. Rodgers, Dr. Aimee, and for Tiffany as well. I only want to make you a couple of questions. Dr. Rodgers, can we get your book from Spain?
All right, I was muted. So there is a European version that's in British English, and hopefully soon it'll be in Espanol as well. But right now it's interesting because there had to be a translator from my American English into British English, which when I read it, it was so fun to sort of see some of the differences because I thought it would be the same, but it's not. Not just spelling, but they use the word diapers, right, as like nappies. They don't use the word uterus a lot, actually. It's more womb. They use the word womb a lot. So instead of P, it's we. So there was a lot of changes, but right now it's only in 2 types of English and not in any other languages. But hopefully, in all seriousness, this is a book that is a very diverse book for the age it's going for is 10 to 14-year-olds about their bodies. And it's very similar to sort of some of my TikTok stuff that's not fertility, that more like teen puberty period stuff, protecting yourself against unwanted pregnancy, which is certainly not this patient population, but sexually transmitted infections. But it's the thing that's very different than any other book out there is it's very racially diverse, size diverse, gender identity diverse. And so hopefully, I hope that every young person who has a vagina out there can sort of see themselves in the pages of this book. But it was a really fun project, and it's nice to see that it's like finally released. So thanks for your support.
Cool.
That's so great. I want to get a copy in both British English and regular English.
Actually, it's just I'm doing another webinar tomorrow about the book, so you can check. I'll post about it later, but you can like Amazon, Barnes and Noble, Walmart, all the places. $14, can't beat that.
And Dr. Aimee, are we gonna see each other in New Orleans for the ASRM?
I hope so. I love New Orleans. Any opportunity to hang out with people that I love seeing, I will do it. So hopefully I'll be there.
Yes, I'm hoping to go too. We can all hang out. We can do we can do a live Q&A from ASRM.
That would be fun.
Over
Let's
beignet.
do it.
You know that I am taking notes, right? So
Yes.
we will do it in our studio there. But please, can you summarize in 30 seconds this talk between the three of you? What do you want to say to the people just to finalize for our colleagues, but also for the patients that are here today?
You want me to start first? You want me to start? Yeah?
Yes, please.
Yeah, I mean, I would just say I find that there's a lot of clinical utility in doing these tests for patients, and patients love knowing what options they have before they transfer. They love knowing that their doctor is thinking about everything for them, and the patient can choose what they feel is right. Having a doctor choose what they think is right for you, I think, is unfair, and I hope that more doctors will see value in doing these tests after, potentially listening to this talk, or having patients reach out after listening to this talk.
I would say that, all of these tests, I've not only been impressed over the years that it's been around, how it's always improving, how, it used to be every 24 hours, now we can get every 12 hours, right? Like there's a lot of improvements that we're seeing, but I think it's all these tests are super powerful tools to help patients who might otherwise, like maybe other regular standard testing isn't helping them. And I think it can help give us a clue for why maybe other things aren't working and help people be successful.
Tiffany?
And I think obviously over the last 40 years or so, we've made major leaps in this field. And now it's time to focus on more personalization and optimizing, really fine tuning to optimize the processes, whether it's, embryo culture or embryo implantation. And then personalization beyond just, okay, what time should I transfer and what kind of antibiotics do I need based upon my bacterial profile, but personalization on as far as what are the expectations of the patient and what are their goals, and maybe what are their restraints in some ways, and in building the best IVF plan for them that way.
So thank you very much, Tiffany, Dr. Rodgers, Dr. Aimee. Thank you all that are here today with us. And again, we will answer all your questions in a few days or maybe weeks. Thank you again for attending, and have a great end of the day in some cases. And some of us are going to sleep right now. Thank you very much.
It's been a pleasure, you guys.
Thank you.
Bye, Allison.
Thank you.
Thank you so much.
Bye-bye. Bye-bye. Bye, everyone.